Good afternoon. I'm Dr. Bushman. This is Dr. Baker, and we're going to be doing a presentation about our surgical seminar. This is in conjunction with Holland Hospital and our business called Grand Health Partners practice. And so we'll be talking through a lot of stuff about obesity and a lot about surgery. So if you have any questions, feel free to type them, send them in to us, and we will try to answer them when it makes sense with the presentation. And definitely we'll take a bunch of questions at the end. First things first, just to get started, again, I'm Dr. Bushman, and this is Dr. Randy Baker. We're two of the partners at Grand Health Partners. We're mainly based out of Grand Rapids, Michigan, but we tend to go to a lot of different communities and are very actively engaged. And we're really excited to be in Holland as our newest community. We've been doing bariatric surgery for over 20 years. We have thousands of patients in our medical weight loss program. And as much as our experience is focused today on surgery, we've actually done over 13,000 cases now for bariatric surgery. And we really pride ourselves in not just doing surgery, but also having the whole gamut of dietitians, exercise behaviorists, PAs, NPs, and really give a full service bariatric experience. So to get started, just our talk about obesity, it starts with just talking about BMI. Most of our patients have heard of BMI. It's a formula. You don't have to memorize it. There's no math tests, but it's just a way to standardize weight and height, because somebody that's 6 feet tall should weigh more than somebody that's 5 feet tall. So we put the numbers in this little equation on the left, and we get a number. And when we talk about numbers that you don't worry about too much about the names of them. But when we start talking about obesity, it's BMI of 30 or greater. And then we start to hear words like morbid obesity at 40 or greater and super morbid obesity at 50 and greater. We've really seen a huge increase in obesity in the United States over the last 30 years. This is a map from 1990 up to 2008, and you can see the huge increase in the percentage of our population that is technically obese or has a BMI of over 30. And this is the most recent map where now actual percentage of adults that have a BMI of over 30 is now 40%, which is higher than it's ever been in our history. Obesity is a chronic and progressive disease. It's linked to more than 40 other diseases and at least 13 types of cancer. And if you have a BMI of 40 or more, it's associated with a significantly higher risk of premature death or dying early, on average 13 years earlier. As I talked already, we really see a lot of medical conditions, and these are just some of them. Stuff like diabetes, high blood pressure, high cholesterol. All of these diseases put extra strain on the heart, so higher risk of heart attacks, a lot of acid reflux, a lot of joint issues, back pain, knee pain. In fact, we're seeing a lot more referrals to us from the bone surgeons, the orthopedic surgeons, because we reduce the risks of having a knee replacement or a hip replacement. We've seen lots of liver disease. We've seen problems with cancers. When I first started doing this talk, it was about 5 cancers. Now we know at least 13, and especially for ladies, breast cancer, recurrent breast cancer, uterine cancer, colon cancer. And this is a big topic. We really want to try to reduce the risks of that as much as possible. This is Dr. Baker's favorite slide, so I'm going to let him actually talk for a little bit here.
Sure, thank you. So nice to be with you today as well. One of the biggest issues that happens with obesity is that there's inflammation, and the fat cells leak nasty inflammatory mediators into the bloodstream day and night. The inflammation causes a lot of the issues that Dr. Bushman just mentioned, the diabetes, the high blood pressure, things like that. And the inflammation is a problem. The problem is it's happening day and night, and it affects all the different organs. In addition, the fat cells produce bad hormones. And if you noticed a lot of the cancer rates, one of the bad hormones that the fat cells produce is a bad estrogen. And that estrogen is like a fuel on the fire for many of the female-related cancers. So for instance, breast cancer. So if you're heavy, your risk of developing breast cancer is way elevated. If you develop breast cancer, no matter how it's treated, if you're still heavy, particularly in the morbid obese category, then you have a much higher risk of recurrent cancer, of that breast cancer coming back. Endometrial cancer has been taking off like crazy, totally paralleling the increase in obesity. So what happens is the inflammation that's being released in these bad hormones are a constant problem. Another thing that wasn't even on the list, Alzheimer's, is inflammation in the brain. And we now know that those that are heavy have an increased risk of Alzheimer's disease as well because of that chronic inflammation. So when you get right down to the bottom line issue, it's the inflammation and the bad hormones that cause a lot of the medical problems that we see related to obesity.
When we talk about obesity, we were sort of all taught that it was this lifestyle choice or a decision that we all made. And I think most of us that have been working with obesity, we know that it's not. And it's nice that it's also recognized by the medical associations now as a chronic and progressive disease. And so we need to treat obesity like a disease, like we treat all other diseases, which is a multidisciplinary approach. And that's where we help, right? Just like we talked about breast cancer, you don't just treat it with surgery or just treat it with radiation. You put everything together, and that's what gives us the best chance of success. And it's the same thing with obesity. And so that's why we have a multidisciplinary team of not just surgeons, but dietitians, exercise physiologists, behaviorists, nurses, PAs. And it's a great team. We actually have over 50 employees, and the focus is all obesity and trying to give us the best chance to not only lose weight short term, but then keep it off long term successfully. We're going to have in-person visits in Holland eventually once COVID-19 sort of calms down. But right now we already have virtual visits to our office. We also offer anti-obesity medicines. We have surgical options available for people that qualify and need a little bit of additional support. We also have support for people that have had previous bariatric surgery or lap bands. And then what our patients really like is access to big support groups. We don't jump on these. It's really patient run and patient developed. And it's a great way to connect with other people in our local communities who have had these surgeries and can help you through some of the questions or maybe some of the things that you're working through.
So surgery offers a great opportunity for actual help. If you look at the statistics, and this is sort of a sad statistic, but if you look at patients who have a BMI of 45 or higher, so they're in that morbid obese group, the question is what percentage of those patients, apart from surgery, will take their weight off and keep it off for 2 to 3 years? And unfortunately, the percentage is 1% or less. About 3 or 4 years ago, we used to say 2% or less. And the reason was that's what the old study showed. And then a big study came out that showed it's actually 1% or less. And there's a number of reasons. Dr. Bushman mentioned this as well, but it's connected to genetics. It's also connected to environment, and it's a multifactorial thing. And that's why it's now categorized as a chronic disease. You just don't go at a chronic disease with a solution. You have to come at it from all different vantage points. But surgery right now offers the best opportunity to lose weight, to decrease the risk of that inflammatory mediator stuff being released, and to decrease those hormones. And as a result, it's pretty much approved by most insurances today because of the beneficial effects that we see related to bariatric surgery.
We are guided a little bit by the National Institute of Health, or NIH. So if you have a BMI of 40 or greater, you almost automatically qualify. If you're between 35 and 40, the insurances want to see an associated comorbidity, which usually means high blood pressure, cholesterol, sleep apnea, heart disease, or diabetes. And so those are the 5 big ones that we would be looking for if your BMI is less than 40. We also want to make sure that you're psychologically capable of tolerating the surgical changes, which means everybody goes through a behavioral screening. It's usually a pretty easy, painless step. We have tons of behaviorists that are actually great with working with our patients, and they'll help work through. Previous attempts at medical weight loss is probably the thing that's the most variable with insurance companies. What that means for most of our patients to get through this requirement, they do a 6-month medical weight loss program, which means from the time you see us to the time we get to surgery is usually about 7 months. And we have a lot of different ways to sort of get past that. And there's lots of things that qualify for that in the past, but just be a little prepared to work with us a little bit for timing. It's not because we want to slow things down. It's because we want to make sure that insurance is paying for your surgery. Surgery is not cosmetic. I mean, it's great if we can get some cosmetic benefits, but we are doing this because we want to have improved health. And we've hit this a bunch of times, all the health problems that we can have with obesity. Well, it just makes sense if we start to reverse that, we get improved health. And that's our main goal, is that whole list of medical issues. If you don't have them, we're trying to prevent you from having them. Or if you do have diabetes, high blood pressure, cholesterol, that we have a really good chance of getting those better.
And I'll just add one thing with diabetes. The studies have shown that if we can do bariatric surgery before you've had diabetes for 7 years, we have the highest chance of getting you off the diabetic medications. The longer you have the diabetes, you start to burn out parts of the pancreas. So we still do patients after 7 years because they get a significant improvement. But if we can get to patients before 7 years, it's really great to be able to get them off all their medications.
Absolutely. And so improved health, that's the main goal of surgery, but we also have a huge improvement in quality of life. And this isn't so much statistics as it's just the stories we hear from our patients. And it's just really fun to hear these stories. And we could probably spend an hour just talking about the stories we've heard from our patients and how they feel younger, they have more energy, they can play with their kids or their grandkids, they don't hurt so much when they come home at night. I had a young lady in her 20s who did awesome after her sleeve gastrectomy, lost 200 pounds. One of the first things she did is got into an airplane and went and visited her family in Mexico. She hadn't seen them in 10 years because she just didn't feel comfortable with her obesity of getting on an airplane. And it's just those kind of stories that are just really fun and exciting to just see the difference that people have in their lives. And not only do we want this to be the life improvements, but we want to maintain this or sustain this weight and fat loss long term. Here are some statistics to sort of back up what we're saying. We have a really good chance of making medical problems better, almost a 90% chance of getting you off the CPAP machine after surgery, 70 to 80% chance of completely putting your diabetes into remission after surgery, especially if we get to it before 7 years. About a 60% chance of getting you off all high blood pressure medicines and about an 80% chance of getting you off all high cholesterol medicines. So really good chances and much better than just trying to do this with diet and exercise alone. This is another study, and this is basically just a very busy study recapping what Dr. Baker was saying about diabetes. This is by far where we're putting the most research in, and there's tons of support that our surgeries really help with diabetics, especially within that first 7 years after they've been diagnosed.
Yeah, and one more point on that is if you're heavy enough for long enough, you're probably going to develop diabetes. And diabetes is so bad because it affects every single organ in the body. In fact, studies have shown in our country about every minute there's somebody having something amputated because of diabetes. It's a bad problem. And so if we can get ahead of that and try to deal with that before it progresses too long, that is a huge, huge thing. And it's a great benefit for the patients. It also saves money because of the fact that you don't have to pay as much for the medications and all the other diabetic related complications.
I think the other big thing that we get, or maybe people have heard about, is bariatric surgery. Is it safe? And there's been a huge improvement in safety of all surgery, but especially bariatric surgery, to the point where statistically we're actually as safe, if not safer, than actually getting your gallbladder out. And part of the reason is we've learned more, but also part of the reason is we're very thorough at getting you ready for surgery. We have a pretty extensive workup so that any issue that we can find, we get addressed. So when you get to surgery, you're as low of a risk as we can get you.
And you also have to look at the benefit. We talk about the risk-benefit ratio. And the most recent data in Michigan actually shows that the mortality rate's even less than what you see on the screen. And so here's the question. So if you have your gallbladder taken out, does that have a chance of getting rid of your diabetes, your high blood pressure, high cholesterol? Does that have an opportunity to improve your risk of cancers? It doesn't. But the mortality rate for a gallbladder is about the same, and maybe even slightly higher now than bariatric surgery. So when you combine those two together, the bariatric surgery is very safe, but has a much greater benefit. So the benefit risk ratio is very, very good for bariatric surgery.
sort of covered this a little bit before, but this is the NIH criteria. So do you qualify for bariatric surgery? You probably don't know your BMI right off the top of your head. So that's something either your primary care doc can help you figure out. You can weigh yourself and put it in on the internet, or you can come in and see us and we can figure out your BMI for you. But again, if you have a BMI of 40 or greater, that's mostly all you need for most insurances. If it's 35 to 40, then we want to see some of those other medical problems to get insurance to pay for it. Other things that we also want you to do. Number one thing that I think holds people back is smoking. You got to stop smoking. It's not for any other reason other than smoking really inhibits your body's ability to heal after surgery. And you can have some major, major problems if you're smoking. One of the biggest things we see is things just not healing well and something called a leak. And one of the biggest things, if you smoke, it greatly increases your risk for these problems. So that's why we just don't want to operate unless you stop smoking.
And I comment on that. So we've done over 13,000 cases. So we've seen a lot of patients, and this is significant. And I know how it goes. Patients will say to us, so Dr. Baker, let me understand this. You want me to go on a diet before surgery, which we're going to talk to you about in a minute, and you got to stop smoking, and I've got to stop smoking. And the answer is absolutely yes. And here's the thing. I think people think, look, I got to go on a diet. I'm going to be more stressed. I want to smoke. But what we found, and we actually did a report on this and did a study and reported this out, and that is that patients actually do better in the process of getting ready for bariatric surgery and seeing the team. They actually have more support to actually be able to stop smoking in addition to being able to get ready for bariatric surgery. And if we can get you to lose weight and to stop smoking, you have changed your health in a dramatic way. It's a very, very positive change. So don't look at this as a negative, look at it as a positive, and it's an opportunity actually in one instance to get two birds with one stone.
Absolutely. And, most of our patients that have gone through this, it seems like this long process and daunting. But once you get into it, it goes by really fast. And it's amazing how much you can learn and get these health improvements even before we get to surgery. And then you get the huge benefits after surgery. So as much as it seems daunting, it really is a nice process. We're here to help you through the whole process, and you will get lots of support from us. Other things that can sort of slow the process down, if you've had a major health problem, let's say you just recently had a heart attack or a stroke, we just want to make sure that you've healed up and are good to go from that standpoint. Uncontrolled mental illness or substance abuse doesn't mean you can never have surgery. It just means we want to make sure that those issues get under control before we make a major change in your life. We've talked about this already, but insurance and fees, most insurances pay for this surgery. Our office is awesome at helping you work through some of the insurance hoops. So we will help you with that. There is cash pay, there's financing available. Just talk with us. We will work with you to make this happen. If you require a supervised weight loss period, so this is usually 6 months, but sometimes it's as short as 3 months, sometimes it's as long as 12 months. You don't have to do it through us, but we definitely offer it. I think most of our patients do it through us because then you're in our system. You can already learn what we do, and it just helps us get you ready for surgery. Again, it seems like a long time, but when I talk to my patients afterwards, they're very glad that they had to go through this program because they've really learned a lot about what we do. They're learning about diet, they're learning about exercise, and they really feel much more prepared for surgery. And this is our pre-surgical checklist. I told you we were very thorough at getting you ready for surgery. You don't have to memorize all this stuff. But what we're going to do is have you seen multiple times by different people to make sure things work. Now, the good news is we have the ability to schedule a lot of these appointments on the same day. So a lot of times you can see the behaviorist, the dietitian, and one of us surgeons on the same day, and it just makes it easier for your life. Zoom has also made it easier, especially if you live a little further away from the core areas, to zoom in on some of these calls to just cut down on your driving time. Everything sort of starts with this orientation. So lots of information here today. But then the first in-person visit, or well, now maybe Zoom, is going to be the bariatrician consult. That's where we get your official BMI. That's where we start to see what medical problems you've had, what surgeries you've had. Number one, make sure you're a candidate for surgery. And then number two, start identifying maybe any issues you have and try to optimize you for surgery. Through the process, you're going to meet with a surgeon one-on-one. That's where we sort of go through some of this information, but really spend more time talking about surgery and answering your questions. We do some preoperative testing depending on what you need and what your health status is. We do a scope to take a look inside your stomach to make sure there's no surprises there before we do surgery on your stomach. If you're ready for a screening colonoscopy, we can do that for you as well if you're due for one. And so that's our pre-op progress. We also see you very commonly after surgery, and that's because we want to be here to support with diet, with questions, and then just really help you through the process of being successful after surgery and long-term. And long-term success is important to us. Following up with us is probably the most important thing. If you follow up with us, we can find problems. We can help say, oh, hey, you've gained a little bit of weight. How can we nip that in the bud and help you use the tool that we've given you to long-term success? We have medicines. We have different behavioral therapies that we can do. Just like we had talked about in the beginning, this multidisciplinary support is the best thing we can do. It's not just have surgery and see you in 15 years. It's really keeping up with this and using all the tools to make things the most successful.
Yeah, and I think one thing I'd like to talk about now too is how surgery works. Basically, what we find is that in the stomach, there are what are called baroreceptors, and they sense pressure and stretch. There's more of them at the top of the stomach. And what we do is by giving you a skinny stomach, and this is for a sleeve or even with a Roux-en-Y where you give a small stomach, what happens is we take out the stretchy part of the stomach so that more food causes more pressure and stretch, which causes signals to go to the brain to say that you're full and also kicks off hormones that increase your metabolism. And that brings us to the pitfalls, because one of the main pitfalls is avoiding high caloric foods and beverages, particularly beverages. Liquids with calories are the kryptonite of bariatric surgery. And the reason is that liquids with calories slide through either your pouch or your skinny stomach, slide through very quickly, and you don't get the pressure and stretch to give you the signals to say you're full. And it also doesn't kick off the hormones that increase your metabolism. So you just get calories. So our dietitians will go through all this with you, but that's one of the key things. And that is not only is obesity a chronic disease, but once you've had surgery, you need to have a multidisciplinary approach to this to get the best results.
Yeah, we just want you to use the tool the way it's beneficial for you. And if you just drink liquids all day, it just goes right through the system no matter what we do. So great. This is where we really start to get into talking more in detail about the surgeries. So we really talk about 4 surgeries. Really, 2 of them are the main ones: sleeve gastrectomy and Roux-en-Y gastric bypass. We'll talk just real briefly about a duodenal switch, and then also briefly about lap bands. Lap bands seemed like a really great idea about 10 years ago, but unfortunately, long-term, they start to cause problems. So really, we're just taking lap bands out if you've had one or know somebody that's had one. And so we can talk more in detail about that if anybody has questions. Before we get into the actual changes that we make with surgery from an anatomical perspective, I like to just briefly look at what's our normal system. And really, it's a big, long, straight line. If we eat food, comes down the mouth through the tube called the esophagus, and then food enters the actual stomach, which is right here. Stomach has 2 jobs. Number 1, holds food. In fact, it blows up like a balloon when we eat, can get pretty big and hold a lot of food in there until our body is ready to process it. The second thing the stomach does is it makes acid. It's good for breaking down food, but sometimes can back up into the esophagus and irritate it. That's called heartburn or acid reflux, and it's something we talk about a little bit later. Food leaves the stomach and it enters the small intestine, which is this long, skinny tube, which absorbs stuff: calories, vitamins, minerals, nutrients. Food enters the colon, which is this big squiggly question mark down in the bottom, which mainly absorbs water, and then it exits. So again, if I stretch that all out, it'll be one long straight line, but we're not 22 feet tall, so it's bunched up so it fits inside of us. This is the old surgery that we do. This is called the Roux-en-Y gastric bypass. And with this one, instead of that straight line, we're actually rearranging it so that it's in the shape of a Y. And you can sort of see the shape of a Y if you use your imagination here. Not only are we making the stomach a little smaller, as you can see right here, but we're also rerouting the way that the food goes through the system. So it starts in that small pouch. And then, sorry, my cursor is a little slow here. It comes down this way, and then it keeps going this way, which means we're skipping or bypassing the rest of the stomach and a good portion of that small intestine. And if we skip small intestine, we don't absorb as many calories and vitamins and minerals and nutrients. So it's great for weight loss. We really see a lot of benefits, but when we rearrange things, sometimes we get some long-term negatives. And those long-term negatives have really gotten us away from this gastric bypass as being our number one surgery. And so that's why for most of our patients, we talk about sleeve gastrectomy.
So this is the sleeve. And as I mentioned before, basically what we do is we just create a skinny stomach. The portion, you can use your pointer there. The portion of the stomach on the side is actually the stretchy part. And so when you eat, normally your stomach will expand so you can get more food in there. And eventually that pressure goes up, then you get more of that satiety and you get the hormones kicked off. The reason actually the sleeve was started was because the Roux-en-Y gastric bypass, when you rearrange the GI tract, you've got to pull the small bowel way up and hook it up to that little pouch. And that was sometimes difficult in really heavy patients. And so somebody came up with an idea and said, hey, let's do a two-step procedure. Let's take out part of the stomach, because we knew they would get weight loss, and we knew that from ulcer surgeries and so forth in the past. And then once they've lost weight, then we can easily move forward to the Roux-en-Y when we can pull it up and we can hook it up without a problem. What happened is we started to notice at that time that patients that had this sleeve actually did very well, and we were avoiding the issues that we see by rearranging the GI tract. What are those issues? Well, if you rearrange the GI tract, not just for bariatric surgery, but for other things, you open up potential problems like ulcers, bowel obstruction, malabsorption, vitamin deficiency, can't get to parts of the GI tract if you have to. And so that changed the game in the sense that a lot of those issues could be put to the side because they wouldn't happen with the sleeve. And the amazing thing about the sleeve is you take out part of the stomach, but you still have a stomach that does what a stomach does. And that's pretty amazing. You can't do that with a gallbladder. I had to have my gallbladder out a couple of years ago, and you can't take part of it out and still have the gallbladder function. But the way this is constructed, you can. The stomach can still release some acid. It can still mix food, but it doesn't have the stretchy part, which is what impacts the satiety. So the sleeve is, again, the major procedure that we do today. We still do the Roux-en-Y. There's certain reasons in certain instances where we do it, but not as commonly.
Yeah, and we love the sleeve. It's just less for you to worry about long-term as well. You probably have known some people that have had gastric bypass, very effective for weight loss, but it does have these long-term issues. With this, we're not rearranging that intestine, so we don't have those increased issues of ulcers or bowel blockages or vitamin absorption. What's also great about the sleeve is the weight loss is excellent. Dr. Baker touched on this, but when we look at it statistically, short and long-term, very similar weight loss results. On average, we see 50 to 70% excess body weight loss with the surgeries. What that means is I don't expect you to get back to quote unquote normal weight for your height, but I expect you to lose about 50 to 70% of the extra weight that you're carrying around, which for most of our patients is somewhere between 50 to 100 pounds. It depends on where you start. But more important than the actual number of pounds is we're losing fat cells, which again goes back to all the inflammatory mediators and everything that we were talking about in the beginning. We want to reduce inflammation. We want to reduce those fat cells because that's what makes us healthier and gives us the health benefits, and not only makes us healthier, but helps us live longer as well. So that's the main surgery that we do.
Switch it again.
What was that? Oh, yes.
Oh,
sorry. We'll talk a little bit more about that, but we do have a couple other things. We have lots of product here. We used to do, just 3 things: chocolate, strawberry, and vanilla shakes. Now we have hundreds of different products to help you get through everything. We'll also be bringing these products out to Holland as well. You can order them online. We can ship them. So lots of different options for our patients that are recovering from surgery.
And there's an important reason too, and that is when we first started doing these laparoscopically, and our group was the first in Michigan to do laparoscopic Roux-en-Ys back then. The big key then is the liver sits right over your stomach. So you have to put a retractor in to push that liver up. And if you're heavy, your liver's heavy. And so at that time we said, we need to put patients on a pre-op diet to help shrink that liver up, give us more room to work in the abdomen. So we would say, dear patient, please try to lose some weight for your doctor so we don't have to struggle so much with your liver. That didn't work very well, you can imagine. So Dr. Bushman's right. It came up with this liquid that was Optifast. It was very expensive. It didn't taste the greatest. But actually, when people went on that and had nothing else except liquids without calories, they did very well. They actually lost the weight. The liver shrunk up. We had more room. In the meantime, there's been an explosion in very good companies producing very good products. So our dietitians go all over the world to try to find the best food products that we can, the least expensive products that we can find. And we try to offer a whole variety so that we can get you to be very successful. You'll be on this diet before surgery. And then after surgery, you're on liquids for 2 weeks to allow the stomach a chance to heal. And that's really important. It's like if you break your leg and your bone is broken, you come in and we do surgery, you can't run a marathon the next day. You got to let that bone heal first before you start stressing it. Same thing is true for the stomach. When you operate on the stomach, we need a few weeks of just easy type intake, and then we want to gradually advance it from that. So the store is there to help you. It's try to increase your compliance and make you more able to be able to go through the pre-op and post-op dietary changes.
Before we get into that, just a couple more things about the sleeve gastrectomy. I think common questions we get: how long is the surgery? What's the recovery like? So the surgery itself, usually it's 5 small cuts. We do this laparoscopically. Dr. Baker and I also are doing robotic surgery. It's just the newest, fanciest technology, which we both really like, maybe even a little bit less pain for our patients post-operatively, which is great. But most of those cuts are about the tip of my pinky finger. One's usually a little bit bigger, about the tip of my thumb, where we take the stomach out, go in there, make that stomach smaller, fix a hiatal hernia if you have one, and then get out of Dodge. Usually takes hour and a half to do this, depending on the situation. But that's pretty average. Now, we're not looking at the clock when we're in there. It's not about how fast we do it. It's about good, safe surgery. But on average, it's about hour and a half. After surgery, everybody spends a night in the hospital. Not a whole lot exciting happening. You're going to be a little sore. You're going to be a little tired. And then the biggest thing is your brain's like, well, what happened to my stomach? So nausea is the most common symptom that we have after surgery. The good news is we have lots of medicines to help with all this. That's why we keep you in the hospital. And most of the patients, by the next day, they're really starting to get used to that new, smaller, tighter stomach and are ready to go home. Most of our patients take about a week or 2 off of work, depending on what you do. I think the biggest thing I hear from my patients is they're a lot more tired than usual. And that's because your body's using a lot of extra energy to heal itself. And so that's going to just take extra energy away from your normal daily activities.
And you'll be able to walk and do stairs and so forth right away. Most people 1 to 2 weeks off. I've had some of the consumer power people climbing up poles. They may need a little more time off. And then there's a lot of folks that are working from home and they probably do fine with 1 week. And again, it's not because you can't necessarily do something. It's just primarily related to that energy piece.
Yeah, and walking's great. We want you to walk around. It helps prevent blood clots, helps prevent pneumonia, releases body's natural painkillers. In fact, it helps you heal up faster. And so walking's great. Up and down stairs is fine. We just want to avoid the real heavy stuff. Again, more so we don't want you to hurt yourself. We already talked a little bit about diet, but it is liquids after surgery, not because we're trying to be mean, but because we really have to get that stomach to heal. We don't want to be putting solid food in it right when it's trying to heal, because that can clog it up. Number 1, make you feel terrible. Number 2, can pop a hole in that stomach. It's called a leak, which usually means emergency surgery and can take a little while for that to heal up. And so we want to prevent you from getting a leak in the first place. Statistical risk for that is 0.2 to 0.3%. So it's very low, but it's not zero. The best thing that you can do to help us with that is just follow the diet plan. Most people that have had problems with a leak have been people that have eaten something they shouldn't have.
Yeah. So after 13,000 patients, we have some interesting stories.
Yes.
So I'm going to tell you one. Don't be this person. One of our patients had surgery. It was actually a Roux-en-Y gastric bypass. And then she's supposed to be on the liquid diet afterwards. And she went to McDonald's and had a McRib sandwich. That didn't go very well. So we're going to tell you how to come through this process very carefully. Our whole team will just follow us through. You just got to give things a chance to heal. It's just like the leg example again. You wouldn't go run a marathon after you just had your leg fixed. You just got to give it a chance to heal and slowly walk through the process. The good news is once it heals up, especially after the sleeve, you can tolerate most any type of food. It's just that your portion size comes way down. And we're going to help you also to try to work on healthy choices.
I think the first 2 weeks, it's just getting used to that new stomach and getting your energy back. When I see people at 6 weeks, it's one of my favorite times because we're losing weight, we're losing clothes sizes, we're already getting off medicines, people are getting off their CPAP machines. You get to start eating more solid food at 6 weeks. I mean, it's exciting, it's fun. It's like, yeah, this is why we did the surgery. So as much as it's a little recovery time in the beginning, it's much faster than it used to be. And already by 6 weeks, we're seeing huge improvements in not only your health, but your energy levels, and it's already making a difference, which is cool. So why choose us? I think we've covered this already, but we've done a lot of surgery. We've been doing this for a long time, over 13,000 cases. There's 5 of us surgeons that are here. So no matter what's going on, we always have a bariatric surgeon available. Hopefully you never have any problems, but if you do, we're here, and you have somebody that knows how to deal with these issues, which is a huge benefit. If you go to a place that only has 1 or 2 surgeons, they might be both gone, and you never know who's going to be taking care of you in that situation. We also have a huge team where our goal is bariatrics. I mean, this is what we do all day, every day. And so our bariatricians, our dietitians, our exercise physiologists, these are the kind of patients that we're always working with. And so I think that everybody in our team is an expert in bariatrics, which is really cool. Pictures are always fun. I think it's always fun to just sort of see some dramatic changes. I've only put a few up here. We have a lot of these, but it's just fun to see the big difference in pictures. And this is nice husband and wife combo here. Does anybody have any questions?
So while we're waiting for some questions to come up, you can type them out or put them through. I'll hit one of the common questions. Probably the most common question that I get is, Dr. Baker, what about the problem of all that extra skin? And that's number 1.
Yes.
So when I'm snarky, I'll say, well, it's a great problem to have. And what I mean by that is by the time you've lost the weight and you have some extra skin, you're so much healthier. But most people, it's not an issue. The 2 factors that impact extra skin the most is, number 1, your age. The younger you are, the more resilient the skin is. As we get older, we have a little more flexibility and things sag a little bit. And the second thing is how heavy you are. So if you have a lot of extra weight and you're older, you're going to have some extra skin. Most of our patients, it's not an issue. We usually wait 2 years before we do anything about it. Most patients don't need to do anything about it. If they do, we also refer to plastic surgery. And what's really nice about our collaboration with Holland is there's a number of specialists, even in Holland, that we're going to be able to work with. And our goal is to make it so that you can have this whole continuum of care in your own community there in Holland. So you can get the expertise that we have after 13,000 years of surgery and medical programs, but also you can get the experts that you may need for plastic surgery. Again, most won't, but we want to have all of that available. And then we'll make recommendations for you at that time as well.
Yeah, I agree. That's probably the most common question that I get too. And I thought it was going to be like every patient was going to be coming to me after 2 years saying they need excess skin removed, but actually it's been a lot less common than I thought. And if we get to that point, awesome. That's a great victory that we've lost that much weight, and we definitely have ways to help you with that. What other common questions can you think of?
I think a lot of questions are, guys ask me, will I be able to drink water and drink liquids afterwards? I think they're thinking there's a period of time you can't, and there isn't. During the healing phase, you sort of have to phase things out. But a lot of guys like to drink a lot. I'm not saying alcohol, but like if they work out and so forth. And during the first 6 weeks, things are healing. But once you get healed up, you can drink pretty quickly. It slides through pretty quick. You don't want to be using liquids with calories because that'll hurt your weight loss. People are concerned about back to work. We already discussed that. If you have an unusual circumstance with that, we'll look at it. We're going to be seeing you 2 weeks after surgery anyway, so we'll reevaluate. We've gone through some of the risks. This is a very safe procedure. We're going to do everything we can to minimize those risks, and we'll look at your individual factors as well. And one other piece, hopefully you've heard this, but the collaboration amongst the team is very good. We not only have done many patients, but we all work together, and our dietitians and the exercise physiologists and the bariatricians will call each other. We'll be involved to get the best care that we can for you. I think the biggest thing in your brain to think about is that obesity is a chronic disease, and we're going to give you a powerful tool with this. But follow-up is the most important. You want to do the procedure, follow what we say, and then follow up long-term. That way we can keep you accountable and give you the tools that are needed long-term to combat this obesity. Can you think of another question?
No, I think those are great. I mean, I really think,
Okay.
we covered most of everything already, but if anybody does have questions, please reach out to our office. We're always happy to talk or ask questions. If you see us walking around in the hospital or the community, stop us, say hi, and ask questions. I mean, I have a lot of conversations with other nurses and docs and everybody, because that's what we're here for. We're here to answer questions and really be an advocate for your health and try to have you be healthier and live longer and be happier.
And we'll be doing a one-to-one with you as well. If you proceed, we'll have a chance at that point. I usually recommend patients to write the questions down. It's funny, patients will come in the room, they've had 10 questions, and they'll I don't know if it's the white coat or whatever, they'll look at you and everything goes out of their brain. So just jot them down ahead of time, and then we'll answer the questions and try to help you get the best prepared that we can.
Yeah, I love questions. I think we all sort of have this teacher mentality. We love teaching our patients about obesity and bariatrics and what we do. So please bring questions, ask questions, call us. We're here. You can self-refer or you can see your PCP and they can refer. We're just here, happy to help. We're excited to be in Holland. If you have any other sort of burning interest or questions, we have tons of information on our website as well. So please check that out. I'll leave this up for a little bit. But thanks for coming, listen to us, and we'll hope to see you soon.
Thanks.